My name is Elisabet Hagert, and I'm very happy to join you from Doha, Qatar, where I work at Aspetar Orthopaedic and Sports Medicine Hospital. Thank you, Dr. Jeff Ecker, for allowing me to be part of your panel today with a recording on Lacertus syndrome. I have no financial disclosures or conflicts of interest. I do have permission to use patient images and videos, and I do share a lot of videos and online material in my social media, which you can see on that QR code right there. So let's talk about Lacertus syndrome. Simply said, Lacertus syndrome is like carpal tunnel syndrome, but in the elbow. As we all know, the carpal ligament is a fibrous band that is compressing the median nerve at the wrist. Well, the Lacertus fibrosus is a fibrous band compressing the median nerve at the elbow. The first publication calling proximal median nerve compression at the elbow for Lacertus syndrome was in 2013, signifying that PMNE can be treated by simple Lacertus fibrosis release rather than the more extensive decompression traditionally done for pronator syndrome. Since 2013, we've had an avalanche of studies coming out, so we now have 60+ publications available on Lacertus syndrome in PubMed, and in 2025 alone, so far, we've had 21 publications on Lacertus syndrome. So why has this syndrome traditionally been thought to be a rare diagnosis? Well, the key thing is that finding Lacertus syndrome is not possible on EMG. It's actually usually inconclusive due to no axonal injury in the nerve, and it's only sometimes visible on ultrasound or MRI. So Lacertus syndrome is a good old traditional clinical diagnosis. The clinical diagnosis of Lacertus syndrome consists of a triad. The triad is motor exam, sensory exam, and pain at the level of nerve compression. For Lacertus syndrome, the motor weakness is going to be in a pattern that is similar to the axonal distribution of the median nerve at the level of the Lacertus fibrosus, meaning that the compression is initially going to be affecting the flexor carpi radialis, flexor pollicis longus, and flexor digitorum profundus to the index finger. Sensory symptoms are not always present for Lacertus syndrome. If sensory symptoms are present, they will be within the palmar cutaneous branch distribution of the median nerve. Only in cases of double crush syndrome, both Lacertus and carpal tunnel syndrome, will you have loss of sensation in the digits.
Now,
this is the motor exam in a case of Lacertus syndrome. This is a first-time mother who presented with complaints of loss of hand strength and control. She is afraid to hold her baby as she several times has been close to dropping her, not feeling like she has control of her hand. She's been seen by GPs, neurologists, she's had EMG, everything was normal. But as you can see on the motor exam, she is weak when testing her left wrist FCR, her FPL, and her FTP too. A simpler way to test also for proximal median nerve compression at the Lacertus fibrosus is by using what we've called the OK sign. So this is preoperative testing of the OK sign. You test both the affected side and the unaffected side. In addition to doing sensory testing for the palmar cutaneous branch, it's important to do the sensory or scratch collapse test. So what you do is you have the patient seated, upper arms adducted to the torso, slight external rotations in the arms. You push, and the patient is trying to resist while you're pushing. You start by scratching over the Lacertus on the unaffected side, and then you scratch over the Lacertus on the affected side, and they can no longer resist. Additionally, we have recently had a description of using the Lacertus antagonist test or orthogonal kinesio tape test. The tape test will allow for a temporary reduction of pressure of the muscles over the median nerve. So this is what it looks like. You do the OK test, and you see how weaky this
So you take a piece of
colleague of
kinesio
mine
tape.
is.
You can see the Lacertus notch right here, very marked Lacertus. You just take the piece of tape, you go from posterior to anterior. Go like this. Stay strong. Stay strong.
So after the taping, the OK sign is strong once again. Pronator syndrome has traditionally been released through a large S-shaped incision, but my preferred approach is a mini-invasive approach with the division of the Lacertus fibrosis alone. I do these surgeries in Wallant by using infiltration anesthesia, 1% lidocaine with epinephrine, around 20 to 30 cc's, depending on the size of the arm.
So the tripod grip is how you can find the Lacertus fibrosis from superficial landmarks. So place your thumb on the medial epicondyle. Place your middle finger on the biceps tendon, and then naturally your index finger will fall in a position that makes it look like a tripod. And this tripod position will lead you to locate the Lacertus. The Lacertus will be right where you have your index finger. So thumb, middle, index creates the tripod grip for the Lacertus.
So tripod grip is what I use whenever I start planning my incisions. This is how I do my Lacertus release. It's a sped up video. It's going to take you 60 seconds to watch. So I always test the OK signs before I start the procedure. I do the tripod grip to plan the incision. Small transverse skin incision, about 1.5 to 2 centimeters. Blunt dissection through the subcutaneous tissues. Retract, and you will immediately find the Lacertus fibrosis. Identify the proximal edge of the Lacertus, and you do spread, cut, spread, cut, spread, cut to completely release the Lacertus. Once you've tested that the median nerve is released, you test for the OK sign again, and the power will be back on the table. So this is what it looks like. We have a patient at 12:12, they're weak on the OK sign, and after doing the Lacertus release at 12:16, the OK sign will be strong, and that's why it's so amazing to do these procedures under Wallant. In a recent systematic review on Lacertus syndrome, they reviewed 118 papers, 7 were included, 446 patients treated for Lacertus release, very high successful outcomes. 3 patients required later carpal tunnel release, 4 required later superficialis release. Only 2 complications were reported. About 11% of these patients have had prior carpal tunnel release with failed resolution of symptoms. Just a little heads up that this amazing book by Vincent Martinel from France, The Incredible Story of Lacertus Syndrome, is now available on Amazon, and it's a wonderful story on how to teach yourself as a clinician to learn how to recognize, treat, and take care of your patients with Lacertus syndrome. Thank you very much for the opportunity to be here today, and best greetings to all of you from Qatar.